Good afternoon, colleagues, and thank you very much for joining us for this session. My name is Arwani Musaisi, and I'll be facilitating this session. And with me, I'm joined by a very distinguished panel this afternoon, and with Dr. Nicholas Crisp, who really doesn't need a lot of introduction, Dr. Mothudi, Dr. Bomela, and Dr. Coetzee. In this session, we'll be looking really at the NHI and really unpacking the sustainability of the national health insurance system. And really looking at sustainability, we all know that this is very important for both patients, for payers, for suppliers, and for society at large. And that, as we begin this session, we'll request that you make use of the chat button if you have any question that you want to ask. And after the panels have presented, we'll then be able to take on your question. And sorry. As we all know, the National Health Insurance System or the NHI, is South Africa's answer to the World Health Organization's call for universal health access to healthcare. And as a consequence, we now have a draft legislation that is sitting with Parliament. And unprecedented, I would say. We have had so many different submissions being submitted to the Portfolio Committee on Health on this, showing that the broad interest from the whole of society on this, including a number of organizations, including Summit, that have submitted our thoughts and ideas in terms of the NHI. This really shows how important the issue of universal health coverage is. So in this session, as we look at the universal health care, the gaps that threaten sustainability and opportunities within the public and private sector. We'll start with Dr. Nicholas Crisp, the Deputy Director General, actually the acting DG at the National Department of Health. And he really doesn't need a lot of introduction because for many years he has been in the health sector and has done management consulting across the African continent. He's also a key developer and official spokesperson on the NHI. Before even taking on the role of having been the DDG and the acting DG at the moment. Dr. Crisp, I'll hand over to you and then you can provide your presentation.
Thank you very much, Aluwani, and greetings to the colleagues on the panel and greetings to the audience for today. So one never knows where to start and how much the audience knows and doesn't know about national health insurance and the intentions of national health insurance. But because this is a panel, I'll just keep it quite high level with just a few remarks. So the first question is, what is national health insurance? And the answer is, it is a financing system that changes the way that we look at money so that when we strive for universal health coverage, which is to get more services to more people with no cost or less cost at point of care, we have a design system that pre-finances all of our healthcare. The outcome that we are trying to get to is that none of us, poor, rich, sick, or not so sick, should never have to pay for our healthcare at the point of care when we are desperately ill, because that is where sometimes we don't have the budget and we are unable to finance our healthcare, and you get suboptimal care if the biggest worry is finances. So the idea is to try and pre-finance everybody's care. And yes, you got it. It's pre-financed from tax. So the question is going to be, what are we going to get by way of care and who's going to pay for it and how are we going to keep us all honest in the system? And I'll just deal with those 3 points. So at the moment, we have a very complicated health system with 2 completely parallel ways of doing things. One in the public sector that looks after somewhere between anywhere around 85%, depending on how you count it, of the population of 60 million people. And we have a private sector that looks after somewhere around 15, maybe 16% of the population of that 60 million people. The problem is that collectively, although we spend 8.5% of our GDP on healthcare, which is a good amount to spend for a country of our size and status, only half of that is spent in the public sector on the 85%, and the other half is spent on the 15%. So there's inequitable resource allocation. And as a result of that, the way in which we buy healthcare, let's call it we buy healthcare, is very distorted. And there are opportunities within the current structure for waste and for theft and all kinds of other over-servicing issues, which I think we're mostly familiar with. So the system, as it is structured at the moment, results in very poor outcomes for the amount of money that we collectively put into the pool. And national health insurance is a way to systematically, over time, change the way in which this 8.5% of the GDP that we spend is used to purchase benefits. So we talk about purchasing benefits, and the benefit is, if you like, a measurable healthcare element or outcome. And in the primary healthcare environment, it's a collection of preventive, promotive, and interventive healthcare. And then, of course, when we need to be referred, it's at a higher level in hospital care, can go right up to very sophisticated and fairly complicated healthcare that's obviously more expensive. So all of that needs to be paid for. And the intention of the bill that's in Parliament is to create a vehicle that will channel that money differently from how it's currently channeled. So what does that mean? It means that a Schedule 3A entity, now Schedule 3A is the schedule of the Public Finance Management Act that allows for the creation of entities that are outside of the government, but still within they're outside of the public sector, but they're still within the ambit of the government's body. So it's a government entity, but outside of the health department and outside of the public service. This entity, once the bill becomes an act and creates it, will then be responsible for determining the benefits, working out the costs, developing the procurement of the goods that will be used, the medicines and the other consumables that will be used in the delivery of the services, and then for paying the providers. So it needs to register and accredit the providers, both public and private sector, who will be delivering the services. So the big challenge, the first challenge, is how to get the money out of the public sector into the fund. And that is at the moment quite complicated because it's done through what's called the provincial equitable share in the annual budgeting. So more or less half of all the non-debt repayment money goes to the provinces, and it's allocated on a formula for the global provincial spending. And then within the province allocates to health and to education, to community policing, etc., to their functions. Collectively, those budgets are then added together, and loosely we call them the health budget, but in fact, there's no such thing as the health budget. There are 10 health budgets, the national department and the 10 provincial departments. The challenge, of course, is that that is 1/3 of the total, more or less 1/3 of the total amount of money allocated to the provinces. And if you want to nationalize that into this entity, the functions of the provinces need to change and be taken away as primary assigned functions, and then only the provider functions would be allocated back to the provinces as providers of services in competition with the private sector, who will also be providers of services. The second half of the money is also complicated because at the moment it is primarily spent by us who in the country who have medical schemes. We voluntarily become members of those medical schemes. They are quite complicated. There are at least 74 of them. And that means that we have a lot of administration associated with them. So that's the second big challenge, is to move that. And I won't go into the details of how to do that now. So the last comment I want to make is, how do you keep this honest? And that is the challenge that everybody is concerned about in Parliament at the moment. So what the bill does is it creates a fraud and corruption imperative, both physically as an entity or a subcomponent within the National Health Insurance, but it also makes it obligatory on the fund to set up a fraud prevention and corruption management framework, which we are currently busy with at the moment, and to make sure that everybody is kept honest. The public, who are the beneficiaries, the providers of the services, the staff, and anybody else who might try to take the money that is earmarked for patient care. So in closing of my opening comments, I just want to say these kinds of things are very complicated. Even for those of us who work with them every day, they are complicated. So it's not going to happen overnight, and it can't all happen at the same time. And it's not as if when the bill gets passed, suddenly you switch a switch and the National Health Insurance just functions. There are lots and lots of administrative procedures, standard operating procedures, digital systems that need to be built, contracts that need to be entered into, reforms of the actual delivery of the services, and so forth. So we are on a journey as a country to reform the health system, and it's going to take us a long time, but we have no choice. We really need to do something about our inefficient system we have. I'm going to leave it there just for opening comments, and hopefully it'll come up in questions. Thank you very much.
Thank you, Dr. Crisp. Thank you very much for those comments. If I were to summarize what you said, is that the NHI is actually a financing mechanism that is looking to combine all our resources between the public and the private sector to get better health outcomes. But the way of getting there, you say, is complicated, and that all of us have to find a way to get there. Up next, we're going to get the private hospital point of view from Dr. Dumisani Bomela, who will give us more, his perspective on this. He is currently the CEO of HASA, which is the Hospital Association of South Africa, the Industry Association for South African Private Hospitals. Dr. Bomela's professional career started in the early 1990s. He has extensive experience of working as a clinician in both the public and private health sectors, as well as in professional affairs management and policy analysis. Welcome, Dr. Bomela.
Thank you very much, sir. Can you hear me? Am I audible?
We can hear you.
And you can see me as well?
Absolutely.
Okay, great. Thank you. I was just setting my timer there. Thank you for the invitation, and special thanks to Dr. Chris for laying out the background against which we're all going to speak. We don't have much time, so I'll get straight onto it. And really, over and above everything that Dr. Crisp has already spoken about, at high level, I think we should see when we unpack the realities of the NHI, we see it as something that must improve access to quality healthcare. And therefore, the goal of universal healthcare, universal healthcare access, is something that must be collective, that we must collectively work towards. And it is noble and commendable. In this regard, there is an urgent need to address the performance of our health system, which is clearly a complex task. And in a complex task such as this one, there's really practically two aspects that we need to be looking at to make this workable. The first one is to optimize the funding, and secondly, to optimize the service provision. And therefore, we have not seen a consolidated strategy document, but it is not difficult to get a good sense of that strategy when one looks around, especially when you consider what has been communicated since the Green Paper in 2011 up until now. So I would like to touch on some of these key issues. I'll really cover very few key issues, but I'll try to expand on them. I'll start from the funding side, the economic considerations. So the worsening constraint of our fiscal envelope will have a severe impact on a purely public funded system. An iterative incremental approach is therefore critically important so that, as they say, we live within our means. Fortunately, the NHI Bill does open this avenue, and we are grateful for that. A single funder and the contemplated role of medical schemes, complementary role of medical scheme, is a major issue that needs a rethink. On one hand, we are constrained in funding sources. On the other hand, we are legislating to limit the inflows of private funding sources. We should be inviting all funding options to come in and invest responsibly and grow our country's investment in healthcare. Limiting the funding envelope could prove to be counterproductive. So there is a risk also that the monopsony buyer that the NHI fund will be, it could set prices too low. While this is attractive in the short run, it erodes the supply chain over time, and it becomes unsustainable and collapses the system in that way. The single payer system also takes away diversity of alternatives when major system failures occur, as they always do with everything. And the contemplated complementary role of the medical schemes when the NHI is fully implemented, the Section 33 of the bill, whatever the motivations in favor of this, it will have unintended consequences for the following reasons. It will result in outright denial of healthcare to many people who simply will not have a fallback whenever the public funder is not able to provide funding for those items that are on its offering, but for some reason they may not be able to fund those. So if we move over to provision, because we said funding and provision are the major issues. Structural problems that exist on the provision side will continue to exist in future, and addressing these in NS cannot wait for a future date, and they need to be tackled now. In the absence of that, the service delivery platform will be unresponsive to population needs. There are 4 areas that most people usually look at. They look at infrastructure, human resources, medical technology, and consumable. But the 4th one, to me, is where the most important, opportunities lay. That is the processes issues, dealing with processes, the operational, how the system gets to operate on the service delivery platform. For some reason, this has not been a focal area of note, but this is where the biggest opportunities for systemic improvements lie. In a system that has big pockets of excellence, collaboration is absolutely necessary, particularly public-private collaboration. Government, as the leader of society, is expected to lead the charge towards more collaboration. The private sector is willing and ready. A raft of overarching pieces of legislation are going to become a law effective when the bill is signed into law. We believe that this may have unintended consequences, and therefore the rational way of dealing with this is for these pieces of legislation to be sequenced iteratively as the various sections of the bill, when it is an act, get activated, instead of them automatically becoming a law. Okay, let me just quickly move as I wrap up. The role of the private sector under NHI, the worldwide trend is that no public funded single payer system has achieved universal access yet. Some may argue for Cuba and some parts of Canada. At the minimum, the private sector's role is to close this gap, but more realistically, the private sector can be purposed to play a major role and significantly relieve the burden on the public sector from both from the funding and the provision side. The private sector therefore continues to play a major role, in primary healthcare services across the developing world. So this is how we see the role of the private sector. And the health system under NHI will be weaker if the private sector is not embraced as the major contributor to the system. And as I wrap up, I think I've run out of time. I had my buzzer. Just unpacking some of the practicalities of the national health insurance system. I think it is important for us. It is important for us to also take the lessons that have been occasioned by the impact of COVID-19, the good and the bad. There's some bad things that have happened, there's the good things. When I talk about the good, I talk about the potential collaboration that was realized, especially during the vaccine rollout. The bad is how fragile our health system delivery platform is. I'll stop at that, just having highlighted those points, Chair. What should I call you? Hulwani.
Thank you, Dr. Bomela,
for
such great interventions. And I think really just summarizing, the key point being that we need to really deal with both the financing side and the provision side of issues. And at the same time, we are then left with a lot of fragmented kind of policies that we need to bring together in order to get to that place. And you really also touch on the core of moving towards a monopoly system. How will that be sustainable in the long run if monopoly drives the prices to points that are not sustainable in the long term? With that, I'll move to Dr. Angelique Coetzee, who's the chairperson of the South African Medical Association. She's going to give us the private health. She will give us the private health professional view. Dr. Coetzee has gained considerable prestige through her work in the health field, and really she's characterized by her insightfulness, passion on health matters, professionalism, and empathy, like a true healthcare professional. She describes her long-standing affiliation with SAMA as mutually beneficial. We look forward to your insights, Dr. Coetzee. I'll hand over to you.
Thank you so much. You can hear me? Okay, great. I'm not used to the earphones, so I would like to say thank you for asking SAMA and to give our view. I'm also giving this view on behalf of most of the doctors out there. SAMA's view on the universal health coverage is that we fully support universal health coverage. It is important that we have healthcare benefits, which is not based on the ability to pay for care, but based on what your disease is and what your needs are for that. So it's extremely important. Current concerns, I'm not going to go through all of it. I think everyone here knows all the concerns, but I want to highlight again quality of care. Quality of care is not currently emphasis enough in the bill. We have said before that we are discussing a funding mechanism or amount and see what can we offer. But it's like I want to go and buy a car and I've got 100 Rand. So what am I going to get for that? I don't know. I'm going to go from office to office and from place to place to see what is available for 100 Rand. It should be the other way around. We need to understand what is the services, what can we afford in those services, and then is there enough money? It's like asking a female to budget for the household income and saying, what can we do with what we have? And not asking the men what they can do with 100 Rand. So very important. We also need to understand the non-independence of the NHI fund. Currently, the powers still a huge problem to SAMA on the ministerial level, that the power that is invested in the ministers. It's been mentioned by Dumisani, the monopolistic purchaser, that is a problem for us. The pilot programs that has been done, this demonstrated little useful outcomes. Actually, we didn't really see all these outcomes. It was never really published around the pilot programs, which is a concern to us. Then there's a lack of detail in a lot of the key proposals going forward. Reimbursement, doctors deliver quality of care at the lowest possible price. Why do you then need a doctor if you want the lowest possible price? You cannot put a price on knowledge, especially if you have been 30 years in a private practice or in a hospital setup, and then to say your knowledge, I'm going to pay you not enough money, the lowest which I can get, and you know what, I'm going to pay you the same that I'm going to pay someone who just qualified 5 years ago. There's absence of the structures to address out-of-hospital specialized care. Then the certification, accreditation, contracting of the health services. We have seen the certificate of need. You know, I'm going to use the word useless certificate of need that has just been published. I don't know what they want us to do with the building regulations that is not even applicable to general practitioners and nurses out there. It is, you know, if that is the kind of services that is going to be enforced of us under this accreditation and credit and certification name, and in the name of certificate of need, it's already a red flag, a terrible red flag. Then there's a lot of principles regarding the equity, the healthcare as a public good, the effectiveness. The list is long. We can carry on with that. So what is important is that, and I'm very, very happy to hear for the first time that National Department of Health actually acknowledged, thank you, Nicholas, that it is a complicated process. And it is a process that's going to take long before you can implement it. We have already seen the corporates moving or preparing themselves in the background as to move into the space of primary healthcare. We have seen what is now currently happening in the space of GPs. So again, you know, we need to be vigilant. What is universal health coverage? Who's going to be the role players, and what services? And then is there money for that? Again, Dumisani also mentioned this, the lessons that we learned from COVID-19, it actually exposed the healthcare, regardless whether it's public or private. None of the two systems are systems that we can be extremely proud of. Each and every system's got their problems. We need to address these problems. The inefficiency was highlighted, and if we can't get that right, and then again, you know, we are waiting for the fourth wave. In between the three waves, nothing really happened. There was not big changes made. So it is as if we just struggle from one wave to another wave. If that is going to happen with national health insurance, trying to fund a universal health coverage system, we are going to be in trouble. Then I think what would be good, and Nicholas mentioned it, is that the competition between public and private sector, especially in the hospitals, that might be helpful in getting better outcomes and services. So yeah, all in all, if we look at the current system, you know, I think we need to measure ourselves around the COVID-19 and how we responded to that, and how we are going to respond in future with the fourth wave, so that we can benchmark ourselves whether we can get that right, because that actually tells us about nearly all the inefficiencies in the healthcare system. If we can get that right, and once if we get into a fifth wave and everything has been sorted, then we can start to say, yes, maybe universal health coverage can work in South Africa under an NHI funding model. Thank you.
Thank you, Dr. Coetzee, for your perspectives and really highlighting the idea that, you know, the quality of care is not currently highlighted in the current bill, and that both the public and the private sector have their own shortcomings in terms of delivering the best care. But ultimately, that this is a complicated process that should take a long time and should definitely be considered more thoroughly before we can get to the achieving universal health coverage, which is a goal that we all aspire to. Up next, I have Dr. Mothudi, who will share a private health funder perspective as the Managing Director of the Board of Healthcare Funders of Southern Africa. BHF is a member organization representing the interest of its members from the medical aid or healthcare funders industry in 7 countries it operates in. Over to you, Dr. Mothudi.
Thank you very much, Program Director. I've prepared a few slides. And as is customary in discussions like this, we end up carrying similar themes in our discussions. The central thread to my talk is mainly around resources. I think the brief was around finances, a bit about fraud, etc. And I've tried to touch on some of these issues. So First, and my slides are not moving. Just a second. Okay, let me talk to them. It looks like so the first thing I thought I should remind the audience about is that NHI is but one cog or spoke in this wheel of healthcare structure and healthcare reform, and we must not lose sight of that. WHO talks about the 6 pillars of a good healthcare system, and this includes governance and leadership, the workforce, service delivery issues, information technology, medicine and other technologies, as well as financing. And the last part is the one that really talks about healthcare. So when you look at our ecosystem, we should not be blind to all these elements and all the other laws that are necessary to actually fix our healthcare system. And we often get ourselves into trouble when we say NHI is not a silver bullet. And if we forget that important element, that over and above the law and the bill that needs to be put into place, there are many other elements that we need to look at. The second area is we should not forget the status of our country, and not just healthcare. So when we're trying to find solutions through NHI and all other health reform initiatives, we should have in mind our stark realities. In terms of the finances that we will be talking about, and I think Dr. Crisp laid a very good foundation here on, we should not be blind that we have a shrinking tax base. Whether you're looking at the perspective of increasing unemployment, the continuing threat of immigration, there is a challenge in terms of where to get more money from. The second area is that there is an increase in the burden of disease and also the healthcare needs. I don't think we need to look far. The past 2 years, we've had an unexpected visitor to our shores, to the entire world in the form of COVID. And we had to scramble around and look for resources that were not planned for. But over and above that, we have ongoing challenges in terms of the burden of disease. The third component is that we have social determinants of healthcare that remain inadequately addressed. We are deep in election season, and issues like this are very topical. Water and sanitation, etc. We should be cognizant that while trying to fix healthcare, we should look at the environment and make sure that everything else that has a potential of affecting the healthcare of our country must be addressed. Now, all these things either are taking away, that I mentioned now, are taking away from the resources that are available, or increasing to the need to have more resources. Now, when you look at what we are trying to address in terms of implementing universal health coverage through NHI, we're basically trying to fulfill the requirements of Section 27 of the Constitution. I had highlighted Section 2 specifically, that the state must take reasonable legislative and other measures. And the important part for me is within its available resources to achieve the progressive realization of each of these rights. And that the rights includes healthcare services, or, food and water, social security, etc. So we should not be in a position where we think that everything that is required within a health system will be made available when we have NHI or UHC implemented through NHI. The state can only do as much as the resources it has affords them to do that. Now, I was premising the argument that the state can thus not do this alone. So Dr. Bomela has referenced lessons from COVID. I want to mention a few points as well in that regard. The first thing is that healthcare can be very costly. When you look at COVID, from testing, treatment, sadly, most of the admissions were either in high care or in ICU. So it can be very costly to provide for the healthcare needs of the country. Secondly, it drives the economy. I mean, the entire world shut down. We're still going through intermittent lockdowns, and it has dire consequences on our economy. And it's important. I think I saw a question in the chat room around whether there is an option not to implement NHI. There is no option not to reform our healthcare system. It's filled with challenges, whether you're looking from the private side or the state. It's filled with challenges. And for us to be able to provide the healthcare that the country needs, we really don't have much of a choice. The third point is that we are in a resource-constrained environment, and I've alluded to some of the elements that attribute to that. So structured collaboration is not an option, but it's a necessity. And this must be with the state, non-state entities, the supply side, and I think Dr. Coetzee and Dr. Bomela has expanded on that. And the last bit here is also we need to empower the health citizen. If we do not take people along in whatever laws that we are implementing, policies, etc., we may have challenges that we are currently seeing now with vaccination, where there is a lot of apathy and hesitancy with the vaccination process. When it comes to fraud and corruption, the fund, although as expected, would not have a lot of details on the operational issues, we still feel that it's not optimized to combat graft. There are serious governance concerns. Dr. Coetzee has alluded to the concentration of the power in the minister, for example, in terms of appointments and also running the fund. The bill speaks to consultation with almost every decision from almost every level of governance, whether talking about the boards or the committees or even the CEO. There must be consultation with the minister, the appointments as well. And that sparks serious concerns around governance. So we have to consider what has been in place now for a while since the 2008 economic meltdown in terms of governance, the Twin Peaks model of governance. What we see is that there are several already within the executive, whether you're talking about the cabinet and parliament. But we also think that from the financial management side, whether we're talking about the Reserve Bank, there must be a role that the Prudential Authority plays to make sure that we optimize governance and reduce the risk of graft. There are structures that are already in place, and this should be utilized. And I'm referring to the SIU-led Health Sector Anti-Corruption Forum, and also the Fusion Center, which has and those this has shown some level of success with the current issues that we have seen during COVID. So the underlying message is that there is power in collaboration, and these entities that are already in place are already putting that to the test. Let me stop there, Aluan, and then we can discuss further during the question and answer. Thank you.
Thank you very much, Dr. Mothudi. And really, just maybe summing up what you said, that the key is that the NHI is just one single cog in a system where we need to have a broader environmental view, with the WHO recommending 6 different elements. And ultimately, this requiring collaboration across the board in order to resolve the challenges. Maybe if I can pose one question to Dr. Crisp and maybe summarize some of the questions that I saw in the question and answer and chat, and I saw you also answering to some of those directly. Maybe the first question, I think, was, Dr. Crisp, why move towards a national health insurance system without maybe first focusing on resolving or bringing efficiencies in the 2 systems that currently exist, and then moving into a unified system once everything can be able to fit in together?
Thanks very much. So the problem is that resources are finite, whether those are human resources, whether they're facilities, whether it's equipment, whether it's money, it's finite. And at the moment, we spend 8.5% of everything that we earn in a year as a country on our healthcare. We need to take a decision whether that's enough or not enough or too much. Other countries spend less than 5% and get better outcomes than we get, and they have smaller GDPs than ours, and we have to ask ourselves, what do they do differently from what we do? What we tend to do is we go to the United States, who spends 18% of the biggest economy in the world and has outcomes similar to ours, which are poor. And we've got to ask ourselves, why are we benchmarking on services and facilities and structural arrangements which are not ideal for our country? We should be comparing ourselves elsewhere. So we should be looking at countries of similar economic size with similar sets of complications. And the problem is we are constantly an outlier. Doesn't matter whether we're in BRICS, whether we're in SADC, whether we're in, look at ourselves as G20's little baby brother, or how we look at ourselves, we are an outlier. We have the largest Gini coefficient in the world, the most inequitable society in the world. Maybe we could argue that Brazil competes with us. But other than that, there's no country anywhere near the mess that we're in our country. Now, we can debate for a long time about how we got into the mess we are and why we're in the mess we are. And we can talk about, you know, banana republics and how badly we manage things, or we can get into the bullring and we can start to fix it. I believe the time is right to fix many of the things that are wrong. So we have a society where at the same time as people are getting heart transplants and all kinds of fancy intrauterine surgery on fetuses, where 400 kilometers away, people still can't get regular immunizations, they still don't get proper health care, no antenatal care, and so forth. We can be arguing, as we're arguing at the moment, about whether a doctor, a pharmacist, or a nurse should be initiating HIV treatment. And that's a very topical matter at the moment, which Dr. Coetzee and I and others are engaged in. The fact of the matter is there are a large part of the population who will never get antiretroviral treatment from any of the three, period, if we don't reorganize the way we deliver our healthcare. So the question you asked me is, why don't we fix one system at a time? So if you want to fix just the public health system, you have to triple the expenditure if you want to do the same as the private sector. So if you want to benchmark on the private sector, you have to spend a huge amount of money, and then you must do 72% of your deliveries by cesarean section. You must remove the tonsils of every single child who gets tonsillitis, and you must do a whole lot of things which the private sector themselves acknowledge as bad medicine. So neither one is the solution. At the moment, what we do is we argue and fight with one another instead of sitting around the table and saying, what's the common ground? Where's the patient? And I want to agree with those who said during COVID, for the first time, people began to recognize that your health is my health. And if every one of us isn't healthy and our negative health is impacting on the person next to us, the whole of society loses. Nobody scores. We have built amazing partnerships. Well, there have been some banging of heads, but we have built really good partnerships during COVID. We have learned that we can share hospital resources. We might not all be happy with the arrangements, but we can do it. We have learned that we can have one information system that runs the entire vaccination program for the whole country, with service delivery taking place in private pharmacies, in hospitals, in public sector, mobiles, all over the place where we cooperate and we work together. I'm not saying it's easy, and I'm not saying we did it all right, but we can do it. We've even learned that we can get all the laboratory tests from the entire public and the private sector into one database so that we can all understand what's happening with the pandemic. So if we can do these few things together, imagine how powerful it would be if we can share the hospital resources, public and private, so that patients who really need healthcare get it where they need to get that healthcare. But to do that, we need to change the way we pay for it and the way we buy it. And that's what the NHI is striving towards. Now, I've got no illusions. I know from the many years that I've been in the health system that you plan something, and when you implement it, it's slightly different. Over time, you have to adapt and you need flexibility. I've worked in so many different corners of this country that I know you can't have one solution that will work in Northern Limpopo and in Eastern Cape, Lusiki, and in downtown Joburg. You have to have flexibility in the system, but you need a framework. And that framework, at the moment, in the way the National Health Act is structured and the Medicines Act, the Medicine Schemes Act is structured, is not working for us. And we need to systematically change them and change the way that we organize these various bodies. And I think we have learned from parts of, I don't agree with everything in the health market inquiry. It had a very different slant on it, and the reason for it was different from what we do in the public sector. But there are elements of what was stated in the health market inquiry that I definitely agree with, and that we definitely should work together to achieve, just as there are the framework within national health insurance where we have to work to get everybody getting healthcare because they need the healthcare, not because they've got money. So we could talk the whole week, and I'm going to end here to say, it's not about, I want to compete with you. It's about what can we do as South African citizens to get better healthcare for the money that we pour into this big hole at the moment and don't get the outcomes that we want to have. And that's why we need to be engaging in forums like this and with the colleagues from BHF and HASA and SAMA and so forth. It's really important that we talk to one another and work together to find solutions. Thanks.
Thanks, Dr. Chris. I think one of the things that I heard a lot in the discussion, everybody spoke about the idea that we're all united in going towards universal health coverage. And everybody highlighted the need for all of us to be able to collaborate. Dr. Bomela, if I can pick up on you on this one first, my question to you would be, given the NHI bill that is on the table today, what can we do to make sure that we move the needle towards more collaboration and finding common solutions? Dr. Bomela, are you still with us?
Unmute, okay. I am, oh, come on, okay.
Yeah, we can hear you now.
But you also need to see me as well. Can you see me as well? Oh,
yeah,
okay. No. Okay. So I think the issue really is not so much what we talk about on these platforms. It's what is happening on the ground. How the things that we speak about on these platforms, how well internalized or not they are at all levels of administration. And the issue of, and that is why I highlighted the issue of collaboration, because it's, we have the ideal on paper, and how do we now move towards the realization of that ideal? When is the shotgun start? And I think we sometimes deal with these issues as if there will be a time that there is a shotgun start and it's ready to go and we all go. We are already in healthcare. We are already experiencing the problems that we know will confront us moving forward into the NHI era that has now been ushered through the bill. So what we see on the ground is the fact that for some reason, we're just not finding each other. For some reason, the collaboration, which seems like a no-brainer when we talk on a platform like this, is still not happening. And the fact that we agree on that collaboration and we're speaking with the same voice, you would think that if we had this session in 5 years' time, we would be talking about the gains that we've made from that collaboration. But instead, we'll still be asking for collaboration. So there is something that is holding us back. And I cannot put my finger down on it, but I think it's a leadership issue all around. I'm not pointing fingers at any leader in any direction. We are all collectively responsible as people who've got a leadership role in healthcare in finding ourselves. But I keep going to the point that government is the leader of society. and they should lead us in this regard.
Thank you, Dr. Bomela, for those comments. I'll move to Dr. Mothudi and really, again, posing the same kind of question in terms of the collaboration side of things, and understanding that, you know, we are multiple stakeholders with varying kind of interest, if I were to put it that way. Perhaps that might be the reason why we don't always find each other, because we all enter the conversation from, I'm a funder, I'm a supplier, I'm a patient, I'm a doctor, I'm a legislator on the other side. So how do you think we can move the conversation forward to get to a point where all the different competing interests with a common goal of universal health coverage, which all of us agree to? How do we make sure that all the interests are catered for so that we can be able to move forward?
Yeah, I mean, we've spoken about the example of the collaboration in COVID, but it was born out of desperation because there were limited resources. But we have to take those lessons and be deliberate around it. I think we have to recognize that the private sector is largely commercial, and I don't think the private sector should be apologetic about it. It's a structure that is necessary. It drives the economy, it employs people, etc. So sometimes we then take these differences and we entrench them in the different ideologies and forget that the end goal is the same. If we focus on what is necessary, that is the healthcare delivery, the discussion may be a bit easier. Now, these differences, what they have done over time, they have entrenched a deep crevice of a trust deficit. And that's where we have to start. But we can't be incidental. It has to be deliberate and structured. What it means is that the same structures that we have seen, the committees that discuss certain things, we should actually be deliberate about making these at least permanent or have deliberate channels. I've seen in other countries, they even have officers in government who are responsible for public-private partnerships. Largely in our circle, they will be born out of a specific project, and then maybe it follows a tendering process, etc. So the underlying message here is that we should be deliberate. Secondly, we must agree, and Dr. Crisp has mentioned is that we won't see eye to eye on everything. But in any ecosystem, we can find 4 or 5 things that we say, for these 5 things, we've got a common vision. And those could be very easily teased out. Issues of protocol standardization, maybe some elements of supply chain management, issues of fraud and corruption. There's very little argument. Now, I often find it disturbing that we compete on these elements that should either be of sectoral interest or even national interest, instead of saying we are finding each other on these 5 elements and let's work on strategies for those. And if we're able to do that, we will at least, if not eliminate, reduce the trust deficit, and that's what's keeping us apart.
Thank you. Dr. Coetzee, also posing the similar question to you, how do we find each other and really collaborate and move this forward? Because ultimately, universal health coverage is a shared common goal. But at the same time, as healthcare professionals, you are the ones who have to look the patient in the eye and say whether or not you're going to get the service or whether or not you're going to be treated and get the kind of quality outcome. But in the discussions, how do we find each other? Now that all of us understand, we have a common goal, but we're not seemingly agreeing on how to get there.
Yeah, it's a very important question. Thank you for asking me that question. I think one of the critical areas here would be trust. There must be trust between the medical profession and the Department of Health. and the politicians. There must be trust between the communities that you are serving as a medical practitioner or a healthcare worker. There must be leadership shown to make difficult decisions, whether it's going to be popular or unpopular. And then the biggest thing is we need to say universal health coverage. What is the goal of that? Why are we talking about it? What do we want? And we want to have a good outcomes in terms of disease burden for that specific patient. For me to look a patient in the eye and say, listen, I feel a mass in your abdomen. You have to go down the road to the public sector, writing them a letter and say, listen, if no one look after you there, if people take my letter and they throw it in the dustbin, please phone my surgery. Let me see whether I can help you in another way. That is totally unacceptable for me, because I know that that person, it's going to cost them money to go down the road to the public sector facility. I know that patient is going to sit for another 6 hours just to get an ultrasound. I know that that patient might be asked by the attending doctor in the public sector, why did you go to a private doctor? I'm not going to see you. We have numerous of examples of this. It should not happen. It should be about the patient. And that is the biggest question. Whether we have money or not, it needs to be about the needs of the patient. Then something that we also need to look at is the training. We need to go back to the drawing board and say, is the current curriculum for nurses and medical students, is it appropriate? Does it prepare them for the challenges out there, especially in the challenges, especially in the private sector, where they need to go and work on their own? There's no supervision. We need to look at our health professionals council. It is dysfunctional currently. So if we don't get all of this in place, and then we have to look at HR policies. We need to employ the right person for the right post, and there must be career progression through the ranks with proven track records for that, especially in your senior and leadership positions. If we can get this right, it can't be that difficult to get this right. I think we can move forward in providing healthcare. Thanks.
Thank you very much. I would like to thank all the panelists this afternoon really for sharing your insights on this really important question that all of us in healthcare are faced with. And just maybe to summarize, I think we all agree that universal health coverage is really the goal that we are all pursuing, and we all agree that we have to work collaboratively in order to be able to get there. But most importantly, there is an understanding that we have to take a broader view and look at the different elements that need to work together in order to be able to get the kind of system that all of us are going to be proud of. And key among some of these things that we need to deal with is the financing question, which is really the sustainability of the financing side of things, whether it's in the public or in the private sector. We need to get the financing to be sustainable long term and to be able to serve the needs of our country, taking into account the economic situation that we find ourselves in. And on the other side, we also then have to look at the provisioning side of things and really resolve the governance issues, the service delivery issues, the qualification issues, the corruption issues, and many more that confront us as we move forward. But ultimately, I think as a departing thought, I believe it will be incumbent on all of us as the people in the healthcare sector to really start thinking about how do we build that public-private partnership that will really endure and have that trust to be able to work with each other. We always all talk about that we don't trust each other, but I think it's probably maybe time that we all cross the bridge and go to the other side and find each other in order to find the solutions that we need. With that, thank you very much, everybody who was able to join us, and to my panelists, we are really grateful that you could spend this hour with us this afternoon. Thank you.
Thank you, sir.
Thanks, bye.
Thank you, goodbye, everyone.
Thank you.
Good afternoon, ladies and gentlemen. Over the last 2 years, the pandemic has exposed vulnerabilities that threaten gains in health, wellness, and prosperity. The world changed, the pandemic demanded it. The virus continues to mutate. It necessitates ongoing adaptation and innovation, and the proverb, necessity is the mother of invention, comes to mind. There are many learnings to be taken from the COVID pandemic response. Sadly, many have lost loved ones due to the pandemic. South Africa has lost many vital healthcare professionals and specialists. However, the pandemic has also enabled never thought of medical advances and leapfrogged improvements in the health system. Many of these advances are largely in response to the pandemic and the need to adapt, change, and grow. The presentations and discussions during the conference over the last 3 days have highlighted some of these advances and more that are needed. For example, AI, diagnostics, digital health, remote monitoring, machine learning, virtual business and marketing practices, telehealth, one vaccination information system, an increased focus on localization and the African Continental Free Trade Agreement, new reimbursement models, a single transparent repository of clinical outcomes for the country, one HTA agency, gathering and use of data that unlocks value, focused anti-corruption initiatives, a regulatory environment that is agile and seriously considers reliance and convergence with other international regulatory frameworks, structured collaboration, the increased need to ensure quality universal healthcare coverage, and value-based procurement. And care. As Dr. Nicholas Crisp said, your health is my health. The medtech sector can be proud of the pivotal role it has played in the pandemic. It has brought life-saving and essential medtech to patients and healthcare professionals. It has brought solutions and innovations at an incredible pace, and it has shown huge resilience. However, we must continue thinking about how our medtech products enhance access and affordability into the future. Undoubtedly, various other challenges will continue and need to be overcome, be it our growing burden of disease, shrinking tax base, social, economic, and political determinants. We as SAMED stand ready to continue to identify measures aimed at accomplishing an improved and agile health and regulatory landscape that is able to meet current needs and respond to future pandemics. We are committed to collaborating with local and international stakeholders and to assist our members to continue to adapt, be resilient, and sustainable. In closing, I wish to extend my deepest thanks to the following: our speakers, facilitators, and delegates for participating in the conference. Also, thanks to our special guests from the Department of Trade, Industry and Competition, the Industrial Development Corporation of South Africa, the South African Health Products Regulatory Authority, and the Zambia Medicines Regulatory Authority. We thank you for joining, and we look forward to strengthening our relationship with you. Thank you also to our sponsors, Intellectus Campus, Israel Trade Mission to South Africa, Vital Air, the Korea Trade Investment Promotion Agency, and our media partner, MedBrief Africa. We're most grateful for your support. Finally, thank you to the SAMED Conference Organizing Committee, and in particular, Caroline Scott, SAMED's Events and Communications Officer, for putting together this year's program and ensuring that it ran smoothly. Caroline, apart from a few technical glitches, like a power cut at the SAMED offices, the odd background slide that referred to SAMED 2020, and in this regard, Dubai 2020 and Olympics 2020 comes to mind, so you're not alone. Well done on your adaptability and sustained resilience over the past 3 days. Ladies and gentlemen, you have participated actively, and we hope that you have found the conference valuable. With this, we conclude the SAMED 2021 annual conference. I look forward to seeing you in 2022 and hopefully sharing a glass of wine with you. Thank you and be well.